Good evening, everyone, and welcome to the Fralin Biomedical Research Institute of BTC Maury Strauss Distinguished Public Lecture Program. As most of you know, this is our final installment in the series this year, and so I hope everybody will check our calendar again throughout the summer to see the program for next year. I hope it can rise to meet the level of quality that we've been so fortunate to have in this otherwise very challenging year with the pandemic. Before I go ahead and introduce tonight's speaker, I want to take this moment to acknowledge Mr. Maury Strauss, who, as you know, endowed this lecture series and supports it. And with his support, we're able to bring in some of the top innovative thought leaders in science and medicine and policy throughout the United States and the world, for that matter. So, Maury, thank you so much, and to the whole Strauss family for putting this on for the entire community. It's greatly appreciated. So it is my pleasure now to introduce tonight's speaker, Dr. Emery Brown from Harvard and MIT. I just noticed on the CV that Dr. Brown and I are both from Florida originally, so in a way we're neighbors. Dr. Brown did his undergraduate work in applied mathematics at Harvard, and then went on to do his medical degree at Harvard and his PhD in statistics there as well. He served as a research fellow in endocrinology and hypertension at the Brigham and Women's Hospital, and then did a residency in anesthesia at the Massachusetts General Hospital. He held a variety of positions, including a clinical fellow, instructor, assistant, associate professor, and professor of anesthesia at Harvard Medical School. He also serves as a professor of computational neuroscience in the Department of Brain and Cognitive Sciences at MIT, and professor of health sciences and technology at Harvard MIT. He holds the Warren Zippel Professor of Anesthesia position at Harvard Medical School and serves as associate director of the Institute for Medical Engineering and Science at MIT, and co-directs the Harvard MIT Health Science and Technology program. He's also the Edward Hood Kaplan Professor of Medical Engineering at the Institute for Medical Engineering and Science at MIT. Dr. Brown's research has involved developing and applying statistical methods and signal processing algorithms for neuroscience, for data analysis, using sophisticated approaches, including likelihood, Bayesian, state space time series, and point processes. He has used these methods to characterize a variety of functions of the brain, including how neurons in the hippocampus that we know represent position and place, how they represent that spatial information, and can improve the ability to extract signals as well. And he's used other modalities, including functional magnetic resonance imaging, to measure things like the period of the biological clock in the human brain, and also analyzing the heartbeats and electrocardiogram. This program has always carried out innovative research and processes focusing on general anesthesia that we'll hear more about tonight. And that really has opened windows to our understanding of unconsciousness, amnesia, analgesia, even immobility, as well as the maintenance of overall physiological stability. And as we'll hear, a lot of us get anesthetized every year. With an aging population, more people are, and there are issues about how the brain responds during aging to anesthesia. And Dr. Brown has explored this with his rich repertoire of tools. Recently, he's been doing some work on COVID-19 as well, and focuses his tools on that and the effects of that after the disease. In recognition of his many, many contributions, Dr. Brown has received a lot of accolades. I'm not going to list them all, but I think a couple are definitely worth noting. I mean, they're all worth noting. But in particular, he's the only person I've ever had the pleasure to introduce who's been elected to all four of the most prestigious national academies: the National Academy of Sciences, National Academy of Medicine, National Academy of Engineering, and the American Academy of Arts and Sciences. He's a fellow of the Institute for Medical and Biological Engineering, the International Academy of Medical and Biological Engineering, the Institute of Mathematical Statistics, and he's been a Guggenheim Fellow in Applied Mathematics. He's a recipient of the Swartz Prize for Computational and Theoretical Neuroscience, as well as receiving the NIH Director's Pioneer Award, the NIH Director's Transformative Research Award, and the American Academy of Anesthesiologists Award for Excellence in Research. So as you can see, his colleagues and peers think extremely highly of him, and I think you'll all understand that tonight after the pleasure of listening to his talk. So without any more delay, it is my great pleasure to welcome Dr. Emery Brown.
Mike, thank you very much for the kind introduction, and thank you to you and Reed for inviting me. It's a real pleasure to take part in this lecture series, and I look forward to discussing with you the work that we're doing on anesthesia. So I've entitled this "Deciphering the Dynamics of the Unconscious Brain Under Anesthesia," under general anesthesia. And so with that, I just want to acknowledge some of the funding sources that we've had the good fortune to have, including from NIH, our Department of Anesthesia at Mass General Hospital, and the institutes with which I'm associated at MIT. And I just mentioned a couple of potential financial issues which might be associated with the work that I'm doing here now. So I'm going to follow the following outline to describe this work. I'm going to give you a clinical sense of what general anesthesia looks like. Then we'll focus specifically on loss of consciousness under Propofol, and we'll relate it to that, what happens for other anesthetics. I'll talk about anesthesia and the aging brain, and then I want to close with talking about closed loop control of anesthesia and reanimation. That's turning the brain back on after anesthesia. Right. So here are the points that I'm going to make, the main issues, the main points that I want to convey. Brain under anesthesia, I don't know what concept you have of anesthesia now, but the brain under general anesthesia is actually not turned off. It's actually quite dynamic. And we think that one of the primary ways through which anesthetics create altered states of arousal, including unconsciousness, is by inducing and sustaining oscillations. These oscillations, as I'll show you, are quite visible in the EEG. They change systematically with anesthetic class, with dose, and with patient age. And I want to show you that closed loop anesthetics is actually quite feasible. And I'll show you some work that we've done on that, both in rodent studies and also most recently in non-human primate studies. And that I want to suggest that actually turning the brain back on after general anesthesia may be a way to speed recovery and reduce postoperative brain dysfunction, something which is common in patients after anesthesia, particularly elderly patients. And through this, I want to help you understand that general anesthesia is probably an underutilized paradigm. So let me just start with the definition. So what is general anesthesia? So it's a drug-induced reversible state that involves anti-nociception, unconsciousness, amnesia, akinesia, and stability and control of the physiologic systems. So unconsciousness, you're not aware of what's going on. Amnesia, you form no memories. Akinesia, you're not moving around while the surgeons are operating. And reversible, because we bring you into the state and we then bring you out of it, all right? Now, in this, I started, Ralph Leidig, Nico Schiff, and I wrote this review article describing this about a little over 10 years ago. We actually said analgesia here, and this is a technical point, but it's important because when you're unconscious, you can have active processing of pain in the body, and that's called nociception. So the state that you want to achieve if someone's unconscious is not analgesia, which would be treating pain, something you actually perceive, but it's actually a technical point, but important because we acknowledge the fact that when you're under anesthesia, you're actually unconscious. So how does general anesthesia work? Well, it's often said that it's a mystery, and one of the concepts I want to leave you sort of firmly implanted in your minds after this talk is that it's really no mystery. But before I go into the details, let me just say a little bit about how we actually do anesthesia, how we do anesthesia, presently. So we have drugs from different categories that we use in combination. It's what's called balanced anesthesia. And so to create unconsciousness, we might induce with a drug like Propofol, and we might maintain unconsciousness with a Propofol infusion or the inhaled drugs. And then for analgesia, we might administer one of the opioids or a combination of drugs, including opioids. And amnesia, we usually take care of in the sense that if you're profoundly unconscious, you won't be able to form memories. And I'll show you why we feel that's the case when we start talking about a little bit of the neurophysiology here. And then for immobility, we actually give you drugs which actually anticholinergics would actually relax the muscles. Now, if you look here in these categories, you see under amnesia, I have inhalational drugs here for analgesia, the same thing for unconsciousness, and the same thing for mobility. So the inhaled drugs that I'm referring to are, so ether anesthesia was first established in a public demonstration back in 1846 at Mass General Hospital by William Morton. We still use ethers, so sevoflurane, isoflurane, and desflurane are modern day ethers. And you can see why that was an important discovery, because what transpired was we were able to administer just a single drug and basically achieve the anesthetic state. So that was a huge breakthrough. But now what we realize of drugs, because you can use less of each drug and you get more of the good effects and fewer of the side effects. And then of course, as need be, we administer drugs to maintain hemodynamic stability, because one of the most important, one of the most profound side effects of anesthetics is that they depress the cardiovascular system, so to depress the heart and also decrease blood pressure. So just to give you a real sense of what going anesthesia is like here, I'm going to show you this little video, which I like to use to open my talks. And this is a woman, I'm going to show you the EEG dynamics in the first minute or so of a woman that I took care of. You can see it was back in 2013, for whom I administered, general anesthesia. I'm going to do an induction with Propofol. So she's about 60 years of age. She weighs about 80 kilograms, and I'm going to give her a 150 milligram bolus of Propofol. You're going to see the EEG change in real time. So these are the EEG leads. So there are 4 leads based on the, placed on the forehead there. And I'm just going to play this little video and I'll just talk. So the first thing you're going to see, is the EEG gets noisy. So those are eye blinks. So Propofol burns when you inject it into a small vein on the back of the hand. And so this EEG is going to get very, very noisy here. Starting there, you see the noise appearing. And so this is very, very common. So she's tensing up her hands, she's tensing up her arms. And so it's getting real noisy. Now, this is actually going to be very good from a pedagogical standpoint, because you're going to be able to see precisely the moment when the drugs take effect. Just give it another 5 seconds. Watch. Right. Now, see those oscillations, beta oscillations? Now she's going to immediately go into slow oscillations. The slow oscillations get deep, but she's unconscious right there. And then the slow oscillations are going to give way to bursts of breath, where the EEG goes flat, and then burst, and then flat, and then burst. All right. So what am I showing you? So this was her when she was awake. So this was about 5 microvolts or so. And then she jumped right over this. She jumped to the state here. These are oscillations. So these are about 12 to 16 cycles per second. So if I were trying to sedate her so that she could just have a procedure that wouldn't be a surgical procedure, but maybe a procedure which would be uncomfortable, such as a colonoscopy, then this is the state I would try to maintain. I'd maintain her Propofol infusion so that she would stay, with this pattern here, and she would be, somewhat sedated, perhaps arousable, but have less perception of pain. She would have complete analgesia, but sort of a decreased perception. And then she went from there, from C, immediately down to E, these large, slow oscillations. And as a rule of thumb, let's just say, anytime you see slow oscillations like this, think brainstem inactivation. And that's about the same time that she stopped breathing. And if you watched her eyes, if you checked her eye signs, you would see her eyes were fixed in the midline. And then she went into the next state here, which was the burst suppression. So where you saw it was flat, it was bursting flat. And then in between the burst, she had an isoelectric. She skipped right over this state here, the slow alpha oscillation. You didn't see them at all. She would have come back to that in a few minutes later, as she sort of comes out of this very profound state of burst suppression and isoelectricity that she went into. So I want to make 2 points here. The first point is, as you go from being awake into the states of anesthesia, states of unconsciousness associated with general anesthesia, these states here, D through G, are the same sorts of patterns that you see in patients in coma. It's no surprise that it's reasonable to think of anesthesia as a drug-induced reversible coma. That's the first point. The second thing is that if you look at the size of the oscillation, see how this is about 5 microvolts, and here we have a high frequency oscillation with a small amplitude. And while she's anesthetized, as long as we keep the drugs infusing, she's going to be in one of these states down here, which is a large amplitude oscillation and low frequency. And just to quantify this a bit, so this is about 5 microvolts here, 50 microvolts when she's unconscious. So, The EEG under anesthesia, I would submit to you, is the strongest EEG signal there is across all the things for which EEG is used. Let's say to track patients who are asleep, meditation, for cognitive studies, looking or tracking the course of patients who are in coma. And this is because, as we're going to discuss in just a bit, this represents coordinated activity of circuits across the brain. And the ironic thing about this, even though we have the strongest EEG signal, as anesthesiologists have the strongest EEG signal there is, we probably use EEG less than anybody. So the way I'm going to show these EEG signals is not in terms of the raw signals primarily, but in terms of the spectrogram. So we're going to take each signal, and we're going to take the time trace of the EEG and break it down into its frequency components. And we'll display time axis, frequency on this axis, and the color will tell us the magnitude of the signal that we're seeing in decibels. So this is a case that I did a few years back, a 19-year-old woman who was having a small procedure and needed, just sedation or at least unconsciousness induced with Propofol. And so I gave her a 200 milligram bolus right here at the blue arrow. And you see these very large oscillations here that you can see. This is low frequency. So these are the slow delta oscillations that I'm showing. And then she went, after a few minutes, she flipped into the alpha oscillation here, which is the 10 hertz oscillation, and then also maintaining the slow delta oscillation. So you can see right here, you see the low frequency oscillation going up and down, then riding on top of that, you see the higher frequency oscillations. So the higher frequency oscillations are these guys here, 10 hertz, 10 cycles per second or so, but a range between about 8 to 12. And then these are slow and delta oscillations, 0.1 up to 4 hertz here. So she has this combination right here when she's well anesthetized of alpha oscillations and slow oscillations. As long as you maintain the Propofol infusion, this is what her brain is going to do. So this is a classic signature of Propofol. And this is an enhanced case. This isn't like the best case I had in my list. If we were to go to the OR now and record from someone, someone 18 to 35 receiving Propofol, this is precisely what we would see. When you turn off the Propofol, the oscillations dissipate and she wakes up, somewhere over here. So this is Propofol. In fact, we can say even more than that. This is a classic signature of any one of the GABAergic anesthetics. So by that, I mean Propofol works by binding to GABA receptors in the brain and enhancing inhibition. And that's going to be at the heart of how it produces these oscillations. So these are my colleagues that I've worked primarily on this research: Cheng, Patrick Purdon, Nancy Coppell, Ahmad Eskandar, Eric Pierce, Laura Lewis, and Sid Cash. So I want to show you one other little bit of phenomenology, then we'll talk a little bit about mechanism. So the first thing I just showed you was that there's a very rich temporal pattern or temporal dynamic in the EEG. What I also want to show you, there's a very rich sort of spatial pattern here too. This, I have to just remind you about one little bit of sort of neurophysiological factoid. If you close your eyes and you place EEG on your occiput, you can record what's called the eyes closed alpha oscillation. And so what I'm showing you here is we've done studies in volunteers in which we give them increasing doses of Propofol. So this is one of those cases. So this is a young man who's going to receive doses of Propofol. We're going to up to 5 different levels. And each of the levels of the infusion is going to be held for about 14 minutes or so. So it's going to take about a little over an hour to get him to the deepest level of Propofol. And while he's lying there, so he has 64 leads of EEG on his scalp. And these are 44 of those leads. And I'm showing the spectrogram in those leads at each location. Now, if you look back here, so this is the back of his head here. This is his occiput. This is his left ear over here. This is his right ear over here, and his nose is up here. All right, so he's got his eyes closed, and you can see he's got this eyes closed alpha oscillation, about a 10 hertz oscillation. So, sorry, I didn't mean to start that right there. Just go back here a second. This eyes closed alpha oscillation. And so it's one thing that, pretty much all of us have. Maybe it gets a little weaker as we get older. Maybe about 5% of people sort of don't produce it. But it's very, very strong. So what we're going to do is we're going to watch this alpha oscillation and illustrate this concept of what's called anteriorization. And this was pointed out by John Mitchenfelder and John Tinker back in 1977, two anesthesiology researchers who were studying anesthesia in a non-human primate model. And so what's going to happen is, as he becomes deeper and deeper in anesthesia, more deeply anesthetized, this alpha oscillation is going to go from the back of the head to the front. It's going to start in the back, go to the front, concentrate in the front, and then when we turn the propofol off, turn the infusion back, it's going to move backwards. So this forward movement is what's called anteriorization. So let me just illustrate this for you now. I'll just play the little video. Okay, you can see up here the rate at which stop this and start it again here. There we go. So you can see so we're changing levels here. Now it appears in the front here. You can see it's very, very intense in the front. And we're still not at the highest level yet. So now we're reaching about level 5 here. It's even more intense there. It's disappeared in the front and appeared in the disappeared in the back and appears in the front. Now watch what happens as we turn it off. It actually moves backwards, and now you see it's reappeared in the back here, and he comes too. So that movement is called arousal. So, and this was work that we characterized in detail with the help of Eileen Simonser, and then Sujith Vajayan actually worked out a mathematical model actually describing why this will occur. We'll talk a little bit about that when we start talking a little about mechanisms. So all that's phenomenology. All right, so those are things that we can just write down, we can observe fairly robustly. But what does that tell us about anesthetic mechanisms? So before we go to the laboratory, we can, or go to the OR to record data, we can write down a model like this. We can draw a diagram, which, as I said, propofol works by enhancing GABAergic inhibition. And so that's what I'm showing here. So this is a cortical interneuron, and it's actually when you administer propofol, you have its ability to inhibit pyramidal neurons is greatly enhanced. And that happens everywhere in the cortex, and in the brainstem here, and basically all throughout the spinal cord. So that's known. That's just writing down known anatomy. You go to the OR and you see a picture like this. You see these very strong alpha oscillations and slow delta oscillations. You do an experiment like the one I just showed you, and you see this concentration of the alpha oscillation in the front of the forehead. Now, the one thing which I didn't mention is this alpha oscillation in the front of the forehead has a very important property. It's coherent in the sense, if you were to measure the correlation at the alpha frequency at say 10 hertz between any pairs of sites across the cortex, across across the scalp of this patient, you'll see that the coherence is around 0.8 to 0.9, so that it's highly coherent. Or more technically, if you were to compute the cross-spectral, the cross-spectral matrix and take the ratio of the first eigenvalue to eigenvalues, that ratio is going to be about 0.8 or 0.9. So a highly coherent signal, which is concentrating in the front of the head. So that's what we learned from our studies. And then thanks to our collaboration with Nancy Goepel, who's an expert in dynamical systems at Boston University, we deduced that this alpha oscillation was most likely an oscillation going back and forth between the thalamus and the cortex. And so why would it matter, or why would that be important? Because if such an oscillation is occurring, it's particularly involved in the cortex and the thalamus, and you're tying up those areas, it's a very straightforward mechanism for making you unconscious for a couple of reasons. So first of all, remember the thalamus is a very important way station. All sorts of information comes through there. So your visual information, your auditory information, somatosensory information, pain information, it all goes through the thalamus. In addition, if the frontal cortex or the prefrontal cortex is important for cognition, and instead of having like this sort of low amplitude broadband activity that you would typically see, you put in place like this 10 hertz oscillation, then you're going to have a significant impairment of communication, normal communication between those two brain regions. And that's what we think is happening with the alpha oscillation. Interestingly enough, when you look here and you see the slow delta oscillation here, but it has entirely different characteristics from the alpha oscillation. And so one of the ways that we learned a lot about this oscillation was from work that Laura Lewis did during her PhD thesis, in which we recorded local field potentials and neural spiking activity from patients with epilepsy who had grids and strips implanted, both to localize their seizure foci, but also to do research. We're grateful to our colleagues Ahmad Eskandar and Sid Cash, who I mentioned earlier, from neurosurgery and neurology, for making this possible. And so if you look here, so the colors correspond to the location of the electrodes on the scalp that I'm showing below. And if you look right here, you can see that you have this nice sort of irregular activity. This is a neuron which is sitting next to the red electrode. It's pretty much spiking wherever it wants to. Look what happens as soon as the person's unconscious, and here's that slow oscillation being recorded in these three as field potentials, essentially in these three electrodes. You can see, first of all, that the neuron spikes something about every 2 seconds or so. So instead of spiking wherever it wants to, it spikes now, it spikes now, it spikes now, it spikes now. So if the same thing is happening across all the locations in the cortex, you can see why it's going to be very, very difficult for various parts of the brain to communicate if the communication depends upon the spiking. The spiking is very abruptly disrupted. I can show you that a little bit better here in this recent data that we just reported literally just last week in eLife. And this is a collaboration that I had with Earl Miller, very well-known cognitive neuroscientist, and Jake Donahue. This is from Jake's PhD. And so here's an illustration of data that we recorded from a non-human primate. Same thing, administering propofol, kind of mimicking the protocol that I just showed you with the humans. So here's the animal awake. You see these nice sort of low amplitude oscillations, low amplitude, high frequency. You see the neurons are spiking like crazy. And so these are 4 brain regions. So this is the frontal eye fields and the prefrontal cortex. So these 2 areas are at the front of basically at the front of the head. This is the parietal area, so over the parietal cortex, and this is superior temporal gyrus. So this is the sort of the auditory area. So like kind of the front and sort of midway to the back here, if you would. All right. And so if you look at nice, clean oscillations, a lot of spiking activity, quite irregular, very broad band, can spike pretty much wherever they want to. Now look what happens when these large slow oscillations start. You have these very large periods of what are called down states, where there's no spiking, and then very narrow up states. And to quantify this a bit, the average spike rate when the animal was unconscious is about 10 spikes per second. When the animal's unconscious, when the animal's conscious is about 10 spikes per second. When the animal's unconscious, the spike rates drop to about a half to one spike per second. So about a 90-95% drop in the spike rate. And the spiking is quite sparse. So I would submit to you, this is beyond a sufficient condition for someone or for the animal to be unconscious. Now, why do we care about this? Well, you see, in the operating room, you can actually see this. So you can see this in terms of the alpha oscillation, the slow oscillations. So if I would submit that if anything that I've suggested here is correct, you can know using the EEG with very high certainty when someone's unconscious. The reason I mention this is that, you don't hear about anesthesia sort of in general until something bad goes wrong. You hear these reports of, once again, someone was completely was under anesthesia, and there's a report of them being awake. The anesthesiologist didn't realize it. If someone had anesthesia before and they came to me and said, Emery, the last time I had anesthesia and I was awake, the anesthesia didn't notice it, I would administer the propofol and I would track it and tracking the brain state of the patient using the EEG. And once I saw these dynamics like this appear, I'd feel quite comfortable the person was unconscious. And why isn't this the case? Just typically, it's because most anesthesiologists don't use the EEG the way I'm suggesting. And so this is a this is a solved problem in 2021. There's no reason to have have awareness under anesthesia. And even with the fact that anesthesiologists don't use the EEG, it's a fairly rare occurrence. It's like 1 in 10 to 1 in 20,000, 1 in 20,000 cases. But I would submit, but using the EEG like I'm suggesting here, we could make that 0. So this is what I've just shown you, that the alpha oscillations are most likely a rhythm going back and forth between the thalamus and cortex. They're so strongly coupled that normal communications between these two brain regions. I showed you a bit about the slow waves, and it seems like they're like sort of fragmenting, if you would, communication within the cortex and probably across the cortex as well. We showed you that, how the dynamics create these large down states, periods where there's no firing of the neurons, for extended periods of time. And I showed you a bit about this anteriorization, and this may be a mechanism. There's one thesis about how anesthesia occurs, this frontal disconnection. And when the anteriorization occurs, you can see the dynamic in the front of the brain is different from the dynamics in the front of the brain are different from the dynamics in the back of the brain, suggesting that this could be a mechanism for this frontal parietal disconnection, which some investigators like George Mashur have been reporting. We didn't say much about the brainstem, so I put that in brackets. We can come back to that in the discussion. If I show you nothing else during this lecture, I want you to appreciate one thing: general anesthesia is not sleep, and this is important to appreciate. And I'm showing you here just EEG of someone who's awake. So this is like what I was showing you before in the patient before I administered the Propofol. She looked like this, and here's that eyes closed alpha oscillation. You can see it's very robust, regular 10 hertz oscillation that occurs when you close your eyes. Now, we went through the states of general anesthesia over here. Increasing doses of a drug, let's say like Propofol or one of the ethers, and we hold you in this state here. So this is someone who's sufficiently well anesthetized that they're unconscious. Now remember, sleep is entirely different. In sleep, what happens is you start in non-REM stage 1, go to stage 2, stage 3. Stage 3 is the slow wave state. Then you pop up into REM, and you go back and forth between these non-REM states and REM about 4 to 6 times a night, and they oscillate about roughly minutes or so. So this is an oscillation where you're going back and forth between roughly non-REM, REM, non-REM, REM. Anesthesia is entirely different. During anesthesia, you're being held in just a fixed state, and you stay in that state until the drugs are turned off. When the drugs are turned off, the effect dissipates, and the patient eventually emerges. And the reason this is important is that if you think of like the drugs which are used to be sleep medications, if you thought of them as sedatives, or better yet, weak anesthetics, that's a much more accurate description of what they're actually doing, because they themselves cannot make your brain go between non-REM and REM. What they can do is sedate you, and then the hope is that with that sedation, the natural sleep mechanisms take over, but they themselves do not produce sleep. So sedation and but they produce sedation. So sedation and general anesthesia are certainly not sleep. And so one of the things we could look at the EEG like this and see these nice time domain signatures. But what we found is that if we look at them in the frequency domain, it's much easier to see the differences, among the drugs. Here's Propofol, like we've talked about already. This is sevoflurane, as I said, one of the ethers. Here's ketamine that has low-dose ketamine has this very characteristic high frequency oscillation up here at about 30 hertz or so. And this is dexmedetomidine. There's a substantial dose of dexmedetomidine, which produces these sort of large, slow oscillations. And so not only is it easier to see these dynamics, but it's also the case that we can relate them, sort of more precisely to the mechanism through which they're acting. And so we can do a deep dive into the other drugs, sevoflurane, dexmedetomidine, the ketamine, the same way we just did with Propofol. So the oscillations are not an epiphenomenon, but they're actually part of the mechanism through which the drugs are producing unconsciousness. Now, because these drugs go everywhere and they do a lot of different things, there can certainly be other ways in which they're contributing to unconsciousness. But I'd submit this is probably among the principal ways in which the unconscious associated with anesthesia is being produced. It's through the production of these oscillations, which are impeding dramatically the ability of neurons to spike, and as a consequence, the ability of various parts of the brain to communicate. So let me just show you what happens with age. So this is someone who's 30 years of age, and so that's Propofol. Here's someone who's 57. So this guy here, let's say, could be this guy's dad. And you can see there's the alpha oscillation here and the slow delta oscillation, the same as you see here. It's a little lower amplitude, a lower frequency band, but still there. Now here's someone who's 81, right? So this is a woman I took care of a few years back. She had a tumor on her chest the size of an American football. It took the thoracic surgeons the better part of 6.5 hours to remove it. But you can see her alpha oscillations are really faint, and then her slow delta oscillations are faint also. What was interesting about this case is I was able to keep her well anesthetized, 1/3 of the already age-adjusted dose of the anesthetics, because I was tracking her EEG and I could see that she was well anesthetized with just those lower doses. And this, what I'm showing you here too, is very typical. You see how the oscillations get to be weaker as we get older. This is a very typical sort of pattern that we see in the operating room. Here's the part that's a little bit sobering. These two guys are roughly the age. His EEG looks like his, where his EEG looks like hers. When you first see this, and think, like what's going on? Well, we age different physically. It makes sense that our brains probably age differently as well. And so the way to think through this is forget about giving anesthesia for the purposes of putting someone in a state so they could have surgery. Think of it as a neuroscience experiment. So the experiment is you administer anesthesia and the brain produces oscillations. Well, the nature of those oscillations depends upon sort of the integrity of the circuits. So when the circuits are young, they generate very brisk oscillations. As the brain gets older, it produces oscillations sort of less briskly. And when we think about this woman who's 81 years of age, we don't have to invoke anything like Alzheimer's or dementia, but just think of each neuron in the brain. It's been around for 81 years. So that with time, the dendrites don't extend and retract as much. The neurotransmitter release is less. The neuron is much more susceptible to oxidative, damage. The mitochondria don't produce as much energy. So you basically have a wiring system which is old and basically frayed. And how it frays basically depends upon, how well we've been taking care of our brains. And you can just guess what they like. So here is a 3-year-old. Here's a 14-year-old. As you can see, the patterns across the age groups are basically the same, but the ones here with the kids are much broader. So this band here, which goes from maybe about 8 to 14 hertz or so here, in the kids, goes from maybe 8 to maybe as high as 20, 25 hertz or so. And it starts to get lower as you get older. In fact, empirically, we know that the highest in the spectrum of the anesthetized brain under propofol or sevoflurane is somewhere in between 6 to 8 years of age. That's just an empirical observation. And then after that, the power basically declines, as we're essentially showing here. So there are very dramatic changes in the response to anesthesia with age, and they basically reflect sort of brain development on this end of the spectrum, and then over here, sort of aging on this end of the spectrum. Let me just say a few words about closed-loop control of anesthesia. So these are 3 well-known individuals who, had head injuries, and as part of the therapy to help them recover from their head injuries, they were placed in a medical coma. You may have heard the term medical coma quite a bit, in recent months because of, patients being treated in the ICU with COVID. But I'm speaking about medical coma in a very precise sense. Here, it is administered an anesthetic, typically Propofol, to inactivate the brain. And the purpose of this inactivation is to sort of maybe stop seizures or to help decrease, brain swelling, intracranial pressure. So the way this is typically done is you target Propofol until you get burst suppression. You hold the patient in a state of burst suppression. And we saw how easy it is to get burst suppression. The woman with just a standard bolus of Propofol, someone going into her going into burst suppression. As I said, burst suppression is a state of profound brain inactivation. So the idea is you hold the patient in this state for a few hours, maybe a couple of days, maybe several weeks. I think Michael Schumacher ended up being in a state of, was held in a medical coma for almost a month or so. Now, so this is a situation where what the state that you want to maintain is very clear, but it's done manually now. And so, but why not use a computer to help you do it in a very formal sort of control theory, manner? I mean, this is like, the path that your plane is on, and instead of letting the autopilot help you really fly the plane and update the, the commands to the flaps and to the thrusters on a set basis, you try to do everything by hand. So clearly, once you know where you need to go, what the course you want to track, that you want to follow, the computer can do it better than we can by hand. So we've tested this idea out in a rodent model. And so the idea is we know what the state we'd like to be in. So we'll call this thing this burst suppression probability, or burst suppression ratio. And one way to think about it, this is kind of a heuristic description of it. Second, and the fraction of time during that second that you're suppressed, we'll call that the burst suppression probability. So if you're suppressed for 60% of the time here, or 0.6, then you have a BSP of 0.6. So let's say we set something like that as a target. So that's our target that we want to have. All right. So then you measure the EEG in real time, and you estimate the level of suppression that's there based on an algorithm, which we can. You compare the difference between the target and where you like the animal to be, and you use this to change the infusion rate in real time, right? So this is something that we've done now for a number of years, and so we're working on trying to get FDA approval to test this out in humans. But here, let me just show you a couple of cases. So here we had the target at 0.4. The green line is the target, and the black line is what the controller is actually doing. So here we increase 7, then up to 0.9, all right? And then this is how the pump had to change the infusion rate instantaneously on about a 5-second time scale in order to achieve the dynamics you see there. I'll just go over one other case here. So here's the infusion is set at, the target is 0.7, you increase it to 0.9 again. Now this time, instead of going higher, you actually drop it off, you decrease it. So look what happens. So the controller says drop like this. So the pump, we don't have a drug which we can put in which will decrease burst suppression. We can only actively increase burst suppression. So what the pump does is it shuts off. It waits until the desired level is achieved, then it kicks on again and then controls at this different level. So we went through a whole range of different, dynamics of up, down, up, and various combinations. And so this shows that this idea of like closed loop control of medical coma is highly feasible. But that's just for the ICU. On a day-to-day basis in the operating room, it would be much better to have something like this that you could use, particularly if you had cases which were lasting, at least 3, perhaps 4 hours. And so here's an illustration of a system which we've now tested in non-human primates. So the same idea, you have a target, and MOU stands for marker of unconsciousness, and that goes into a control system. And then in real time, what you're doing is you're measuring the EEG. In this case, it's the local field in these animals. So you calculate what the marker actually is. The difference between what the marker is set at and where it is gives a command out to the controller to change the infusion rate. And here our duty cycle for updating here at the moment is every 20 seconds. And so we can decide we can keep the animal in this sort of robustly in this state of unconsciousness. And so here's a bit of empiricism. So remember how oscillations came on, the spike rates dropped dramatically. And so it turns out that a nice marker of this is if you track the power in the 20 to 30 hertz band of the local field potentials, it actually matches very nicely the spike rates in the animals. It will record directly from the animal's cortex. So we know that this marker here that we can see, that we can observe, is going to be a very strong indicator of these spikes, the spike rate dramatically declining, and the decline spike rate was tightly locked to the animal being unconscious or unresponsive. And so this is why we use this marker based on the 20 to 30 hertz as the marker that we're going to now try to control to generate and maintain a state of unconsciousness. Done by one of my postdocs, Suresh Chakrabarty. And what Suresh did was he normalized the marker so that the target should be 1. So if you're above 1, you're a little less unconscious. If you're below 1, you're becoming more and more unconscious. And so what he did first was just let the pump rate, which I'm going to show you here, run at a fixed concentration. And that's what we normally do in the operating room. We just set the pump at a rate and let it run that way for several minutes or more. And then you're going to see what the marker is going to do. Then he's going to turn on his controller. You're going to watch the controller's ability to hold the marker at 1. We're going to raise it down. When to lower it, then we're going to raise it up again. So I'll just go ahead and play this here. So at the moment, the infusion rate is constant. You can see it's being held constant at 0.4 there. It's up 30 minutes or so, 35 minutes have gone by. Now he turns the controller on, and now you can see over here that the controller is holding the target exactly where he wants it to be. Now he's going to change the target, drop it down, so the controller is able to drop down to a lower level. And so he holds each level for about 30, 40 minutes, or increases it, sends the target up, and the controller goes up and grabs the new target. So this idea of developing a closed loop control system is highly feasible. And this is one of the ways which I think we can help reduce, sort of problems from overdosing, but let's say administering more drug than is needed to maintain a state of unconsciousness. And I want one final idea along these same lines. So this is an animal who's anesthetized, and this is work being done by Ken Stroll. So he's studying the idea of turning the brain back on after anesthesia. So this is an animal that's anesthetized with isoflurane, and he's been there for about 20 minutes or so. And what Ken is going to do is he's going to administer a dose of methylphenidate, which is Ritalin. So he pumps it into the line, and he has to flush it into the animal. Now watch what happens. Now, he didn't turn the infusion rate off. He didn't turn the isoflurane off. The animal is still there. He's still receiving the isoflurane, but you can see that the Ritalin induced a very profound state change. In fact, he's coming to as a consequence of this. Now, this doesn't count until he turns over, so he has to turn over. So he's making every effort to do that. He's making very purposeful movements. And he has his foot caught on the wire, so he's having trouble doing it, but we'll see. He gives another oomph, sort of like one more. He definitely makes it. I've seen the end of the video. Here we go. One more. Okay, boom, he made it. All right. So what is Ken doing? So what he's doing, he's administering Ritalin. And as you know, what Ritalin does is it blocks the reuptake of dopamine. And that's this pathway here coming from the top of the brainstem, so the ventral tegmental area, so the midbrain cortical pathway, which goes through the limbic system here. And we think of it as a reward circuit, but it's also important for arousal. Remember, there are a lot of people who self-administer drugs like Ritalin and amphetamine to help sharpen their thinking. This is a bad idea, it shouldn't be done, but they do it because they're in high-stress jobs, and they claim that they're game best when they're able to administer drugs like this. It's not a good idea. But in this case, where you've been in anesthesia and you've had the balance in the cortex, thalamus, and the rest of the sort of the central nervous system shift towards inhibition, maybe giving a drug which would drive arousal is a way to help patients come out of anesthesia and have clearer heads. So Ken has also done this not only by administering Ritalin, but also by stimulating electrically and optogenetically. So this is something we're looking to take forward into clinical trials. So this is what I've just shown you, that the brain under general anesthesia is dynamic. It's not turned off. As I said, one of the primary ways in which the anesthetics create these altered states of arousal, in particular unconsciousness, by inducing and sustaining these oscillations. They're easy to see in the EEG. They change systematically with anesthetic class and drug dose. Maybe turning the brain back on after anesthesia is one way of helping to decrease the side effects of, in fact, the cognitive dysfunction after anesthesia. But also you can imagine if you had nice, tight, closed loop control of the anesthetic, and in addition, you couple that with turning the brain back on, you could probably dramatically reduce the sort of the bad side effects of anesthesia on brain dysfunction, particularly in elderly patients. And you can start to see why, thinking through very carefully how anesthesia works, you start to get some real insights into studying the brain from a perspective which is, as I said, is probably underutilized. I'll leave you with one sort of thought here on this last idea. General anesthesia and altered states of arousal induced by general anesthesia linked to all these other areas of clinical neuroscience. And this is really how we should think of anesthesiology, not as a subdiscipline of pharmacology, but as a subdiscipline of clinical neuroscience. So just like neurosurgery, neurology, sleep medicine, psychiatry. And, there are all these really cool links between what we see, what we do with drugs, for anesthesia care and things like pain. So ketamine is a drug used to treat pain. It's a model for schizophrenia, and more recently it's been used to treat depression. Or the same ideas that I'm showing you to administering Ritalin to bring patients out of anesthesia, my colleague Brian Edlow is now using as a way to bring patients, appropriate patients, out of coma. And as one final idea, if you take a drug like methylhexatol, at low doses it can be used to induce seizures, but at high doses it can be used to actually treat a seizure. So if we take anesthesiology and anesthesia care seriously and think about the neuroscience of it, we can contribute to these other fields and other problems in clinical neuroscience, and also in anesthesia care. And those that are going to benefit the most are going to be our patients. So thank you. I'll stop there.
Thank you very much, Dr. Brown. Appreciate that. We have a question from the audience from Dr. Fountain. He asked, said closed loop control here seems to be an excellent idea, but why is it viewed as radical? Comparable problems were solved in the manufacturing world decades ago. Is the medical profession that is the barrier to acceptance?
You're exactly right. I mean, this idea is as old as dirt, right? And but things are the wheels in the medical profession, and actually, let me just speak about anesthesiology in particular. The wheels of change turn very slowly. In the last 30 years, we've really had no new anesthetic drugs. And most people practice most anesthesiologists or anesthesia caregivers practice anesthesia not by following the EEG, which gives you an idea of what's happening in the brain in real time, but by conventions based on pharmacology. So you're completely right. It's just a sociological phenomenon. The technology is out there right now to improve anesthesia care dramatically, but getting it into place is a real challenge. It's the science of it, because the science, as you suggest, was solved, and engineering was solved years ago.
Thank you. We have another question that you mentioned on your last slide, hibernation. And the question is, how does the sort of pattern of EEG activity one would see in a hibernating animal, or some of the animals that go into pseudo hibernation or deep seasonal sleep compare to the anesthetic effects that you would see on EEG?
Very interesting. This is, there are these hibernation of these states where these animals stay in these very depressed physiologic conditions for extended periods. It's a state that's sort of between burst suppression and slow oscillations. They have these very long sort of what are called these trace alternans dynamics, sort of like these very long sort of profound slow oscillations when they're in those states. And what would be so cool is we could learn how to control human physiology the same way. Maybe that would be a better way to anesthetize people than what we're doing now, because the oscillations that I'm showing you, which are quite different from what I just described, are actually truly pathologic. I mean, we're glad that we have anesthesia so we can do surgery, but they're far from being natural and they're far from being homeostatic.
Pam Jacks asks, what does the spectral analysis look like in Alzheimer's patients?
It's very interesting, when patients are older in general, it looks like this case I was showing you here, usually very faded, low amplitude oscillations here. And I had a slide in here, which I think I took it out. But in general, in older patients, whether they have Alzheimer's or not, you're going to have very, very weak, sort of slow oscillations. And one of the ways that you really can get a sense of how the frailty of the brain in that regard, it takes just small doses of Propofol to not only make the person unconscious, but to have them go to these very profound states like burst suppression. So the amount of anesthetics that's needed for older patients is far less than we currently realize.
Okay, thank you. Whitney Slidham asked, if a patient's taking a dopamine reuptake inhibitor, would the effects of reanimation via methylphenidate be altered?
It's a very, very good question, and it can be altered in one of two ways. So I've seen both cases. So remember, like kids who have ADHD are taking drugs like Ritalin. So the recommendation typically is not to take it on the day of surgery. And the idea is that, it would create an arousal signal, maybe make the kid harder to anesthetize. So I've seen that was the case. And the pediatric anesthesiologist didn't know that the kid was on Ritalin, and they found themselves having to give the kids higher and higher doses when the kid took the medicine on the morning of surgery. And then there are other cases where it seems like the Ritalin has helped reestablish an equilibrium. So ironically, when they didn't take it on the morning of surgery, they actually tended to be more somnolent. So I think there's a person-specific effect. And I think the thing is, it's important to tell the anesthesiologist, like in the case of kids who are on Ritalin, that they are on it and whether or not they've taken it on the morning of surgery, so that the anesthesiologist can know how to adjust, his or her technique and know what to look for, or not be surprised when he or she sees either prolonged sedation or sedation which is not occurring as rapidly as one might anticipate.
And if I may add a question I had for all the world, as I was watching your experiment with the feedback, it reminded me of a voltage lamp experiment spread over time with monitoring and coming back with the opposite current to hold the voltage. So it got me thinking that you might be able to take this into the behavioral domain, either in terms of some kind of real-time fMRI experiment on a patient, for example, or I guess it might even fall into the realm of meditation and behavioral cognitive therapy. That is, could you teach a person with that kind of time domain to have feedback conscious control to drive themselves back into that state?
The answer is yes. I think you could. It's not easy to do, but I think it's totally doable. I mean, I've heard allegories. Like one of my colleagues, told me of this Indian yogi who needed surgery. And actually, but even before I say that, my colleague Bala Subramanian at Beth Israel Hospital in MGH, Beth Israel Hospital in Massachusetts, teaches meditation and uses it as a sort of a pre-anesthesia technique to help reduce the anxiety and stress, and also the like the pain medication necessary for patients. So that's documented. And then what I was about to say is this yogi was about to have surgery, and they said, we'll have to give you general anesthesia. He goes, no, that won't be necessary. He says, I'll put in a trance, and then you go ahead, do your operation. When you're done, I'll bring myself out.
Yeah.
So, and that's exactly what he did. And it was very impressive. I didn't see this as an allegory, related to me by, one of my colleagues, but I think it's totally feasible.
Very interesting. One of our MD PhD students, Oscar Alcareza, says the consistent EEG patterns associated with unconsciousness using various anesthetics is remarkable. Has there been any investigation to see if these interoperative EEG patterns correlate with other systems like respiration or hemodynamics, possibly using EEG patterns to anticipate or monitor acute changes in respiration or hemodynamics?
No, I think this is really on another axis. I mean, this axis here is really, basically coming directly out of the brain. And so these are more sort of like brain effects. Now, in an extreme case, if someone got profoundly hypotensive, you had decreased cerebral oxygenation, then you'd probably see someone going like burst suppression or like large slow oscillations. But other than that, I mean, so think of it this way: your heart rate, your electrocardiogram, and your pulse oximeter are basically telling you about about your cardiovascular system and your respiratory system. And this is finally telling us something about the brain, which information which hasn't been exploited or is underexploited up until now.
Okay. Vince Basile, one of our most regular attendees at these lectures and a physician, says surgical anesthesia requires varying depths of general anesthesia during the procedure. So how does continuous infusion accommodate these changing levels of stimuli to minimize anesthetic dosage? Do you follow the EEG as well as blood pressure, heart rate, respiration rate, et cetera?
I mean, that's what I'm advocating. And in fact, as the requirements for the surgery change, then we should be using the EEG to help us understand that. So for example, if the surgeons move the retractors and we start seeing that the EEG says the patient is waking up, then you can feel very good that you should probably increase your propofol infusion, increase your sevoflurane. By the same token, if the patient's been sitting there for 30 minutes, a half hour, and you see him getting deeper and deeper in the sense burst depression starts to appear, then you should turn the anesthetic back. So this is exactly the idea that I'm putting forward. The EEG should be used to guide anesthetic dosing on a moment-to-moment basis. And then what you'll find is that if you just let the infusions run, and I didn't point this out in the video of the controls loop controller, during the time when the infusion was at a constant rate, the animal's depth was just getting deeper and deeper and deeper, and that's exactly what we see in the operating room. So using the EEG to make one aware of that is, I think is not only doable, but it's actually the right thing to do.
Okay, great. All right, we'll just have two more very brief questions for you, and then we'll wrap up. Wesley LeConte, one of our faculty members here at the Research Institute Medical School, asked, is there evidence that post-anesthesia delirium could be minimized with closed-loop delivery?
There's no hardcore evidence, but I'm proposing it as a possible solution.
Okay.
No evidence yet.
And last question, finally, we'll take, and then we'll have to wrap up. Another one of our faculty members, Dr. Stephanie DeLuc, asked, do these patterns change in epileptic patients?
Not really. In other words, we see the same sort of age dynamics that we see in the epileptic patients. This is pretty robust. There may be some subtle differences, but I'd say grossly they're the same.
Okay. Well, Dr. Brown, thank you very much for your outstanding and provocative lecture and answering the questions. We greatly appreciate it.
Oh, no, thank you very much. Thank you. Thanks.
And thanks to all folks for attending. We appreciate it. Look forward to seeing you at the program next year.
Okay.
Emery, I'll see you in a little while at dinner.
Okay, see you in just a second. Great, thanks again.
Bye. Bye-bye.